Thank you, Max. Just on behalf of my co-chairs, would like to welcome everyone here today. It's really a thrill and an honor to be part of this really great symposium. I'd like to also thank Meg and Michael Werner, chair of the board, and the entire board, really for their leadership in bringing this event together, and also, as Max alluded to, just all the incredible efforts towards research and the different aspects of research, whether epidemiology, diagnosis, new treatments. It really is, as also Max mentioned, a very exciting time to be involved. So it's great to be here. Thank you. So in terms of an overview, this is the outline that I have. It'll be a little bit more 50,000 foot for the first half, talking about incidence, meaning how many cases are diagnosed, symptoms, etiology, in other words, do we know what causes this, the biology, and workup staging. And then just a few more specific, talking about within non-Hodgkin's bucket and Hodgkin's. So what are lymphomas? When I meet a new patient, it's somewhat challenging. As Max showed, you have the badge table out there and how heterogeneous this disease and cancer is. But generally speaking, it's a cancer of the immune system. And that's challenging too, because it is many different parts to our immune system. We all have immune cells in the body, and they conglomerate in our lymph nodes all throughout? We all have little lymph nodes, yes, but there's immune cells in the blood, and where's the blood? Everywhere. So really, and we've known this for a while, even though you might see it in one or two places, is really a whole body disease. And it is the most common blood cancer. So there are different ways to divide it, whether it's through the eyes of a clinician or a patient. The one way to state it is, as I had mentioned in the outline, sometimes there's Hodgkin lymphoma, to say it in non-Hodgkin's, and within non-Hodgkin's, we all have B cells and T cells. Those are part of our normal immune system. B cells have certain functions they do for us, creating antibodies against certain infections. T cells not only fight infection, but fight cancer. And then there's some more rare cells called natural killer cells or histiocytes. And it's really important to understand that. And I'll come back to that kind of cell of origin that we think about. So when we say estimated new cancer cases in the United States, and not to compare and contrast too much, but just to give you a sense, where does non-Hodgkin's lymphoma, it's a male on the left and females on the right, you see non-Hodgkin's falling 7th on the list. And so it is one, though, yes, it's 7th, but within that 5 and 4% of cancers diagnosed in the United States, it's very heterogeneous. So a lot of these other cancers, such as prostate or even breast cancer, are not only more common, they're a little more homogeneous. There's not as many subtypes. And so really it can lead to a little bit of a challenge when you have different little subgroups, but I think it's a good thing. The more we can learn about it and put it into little specific subgroups, the more specific and targeted our treatments can be. Another thing to think about in terms of age at diagnosis this is Hodgkin's and non-Hodgkin's, but just to concentrate on non-Hodgkin's, and this is true for many cancers in the world. In other words, that the incidence increases as age goes along. You can see, especially as an aging society, it's something that is partly thought to be as we age, our normal immune surveillance weakens a little bit. And so can that be part of the reason why, as you can see, this is cases per 100,000, so it's not an absolute number, but you can see that rise with age. Now this is looking at what about the epidemiology or age-adjusted incidence in terms of by year over the last few decades. And interestingly, look at 1975. Now this is kind of relative per 100,000, but you can see from 1975 to 1995, the incidence doubled. In other words, twice as many lymphomas diagnosed in the United States over that 20-year period. Now, why was that? Well, I think there's a few different reasons. The start of HIV was part of that. So we know anyone with HIV, or frankly anything that impairs the immune system, will increase the incidence of lymphoma as well as other cancers. But even when you take out HIV, there has been a slight increase. And frankly, a lot of hypotheses, we don't know exactly why. Now it's leveled out, as you can see a little bit, over the last 10 to 15 years to that incidence curve. And this is fresh, hot off the press from the NCI website. A little different for men versus women. Men are in red, women are in blue here. So you can really look at this in different ways, by race, by gender, by age. And this is what I'm showing you as non-Hodgkin's, not Hodgkin's disease in terms of this incidence. I'm going to go through this a little quicker. And so slight differences based on race that we can see. And there really is research digging into this to understand not just, oh, okay, that's interesting, but why is that? And what can we do about it? Whether it's a prevention or preventing a recurrence or a treatment. I think one thing that's really great to see is mortality. And we know this in lymphoma, which is absolutely fantastic, that really, especially since the year 2000, that the survival rates have improved, really across the board. And that's due to a host of factors, certainly better treatment, earlier diagnosis, better supportive care. And we want to obviously keep that ball rolling, keep obviously increasing cure rate. So I alluded to this earlier when thinking about non-Hodgkin's lymphoma, and it can be confusing for a patient the first time. They think it's one disease, non-Hodgkin's, when really on our new recent classifications that gets updated every 5 to 6 years, if you count up all the different subtypes, there's now more than 80 different subtypes of non-Hodgkin's lymphoma. And again, in a way that can be confusing, but it really is a good thing. And why is the number of subtypes increasing? It's because we learn more. As we learn more about the biology, we learn more about the disease, we're able to put them in certain subgroups, which is a good thing. Because as we learn more about it, it becomes more specific. It's not just one lump group and everyone's treated the same way. And really what's driving a lot of this is the biology. As we learn about literally the DNA and the RNA and the protein of these different lymphomas is really fascinating and interesting. There's also some clinical kind of distinctions here depending on where it can present in the body as well. Hodgkin's is less heterogeneous. There's 7 different types, as I'll talk about, and they're mostly treated the same and viewed the same. There's maybe 1 or 2 different slight differences in terms of those subtypes. What about symptoms? You know, there really are no specific symptoms. What are some of the more common symptoms that we'll see? Well, sometimes it can be the lymph nodes, which normally are small, but they can start to grow, and depending on where they can grow, it can maybe start to push and cause pressure in a certain part of the body. There's a term that we use medically called B symptoms, B as in boy, B symptoms. B symptoms designates 3 items, high unexplained fevers, drenching night sweats, and unexpected weight loss. And that's something that is not seen in all lymphomas. It's a little more common in the aggressive lymphomas, but we can see it in the indolent lymphomas like follicular. Fatigue sometimes is a presenting symptom. Some patients will be anemic, etc. And again, depending where it is in the body, you can see different symptoms related to that. What about risk factors? And so there is a decent amount of research here. There's more on the treatment side of the aisle, but this is the epidemiology, in other words, what causes it side of the aisle. I think also very important, because not only can it help us on the cause, but maybe this can also lead to help in preventing recurrence, if you know what caused it in the first place. And there is not one smoking gun, and it probably never will be, and that's true for most cancers. We've not found a true genetic link yet, although there's a lot of research on that. We know, as you see, the word that's resonating a few places on the slide is the immune system. So the immune system is critical. Anything that decreases the function of the immune system, so whether it's an infection like the HIV virus, whether it's an autoimmune disorder, rheumatoid arthritis, lupus, etc., whether it's organ transplantation, in other words, anyone who receives an organ transplant, like a heart transplant, a kidney transplant, liver, has to go on immune suppressant medication so your body doesn't reject that organ. So once you go on immune suppressants, your risk of lymphoma goes up quite a bit. We call that PTLD if that's diagnosed in that context. Now, are there certain chemical pesticide exposures? Radiation, we know, sometimes can cause it. So, and also, interestingly, certain bacteria and viruses we know, because there actually is a lymphoma, Malt's lymphoma of the stomach, that we can literally treat with an antibiotic. We don't need chemotherapy sometimes, or radiation, or rituximab. So a lot of really good, great research going along this risk factor cause. So this is a little bit of a complex slide, and it's one that maybe I would even show to medical students or residents, but I think what it shows is in the normal body, in all of us, in our lymph nodes, and Dr. C can probably speak to this better than I, but our B cells will mature in the lymph node. They have to become acclimated. They have to learn how to fight infection. And so there's very organized steps that they'll go through in certain zones and areas of the lymph node that the normal B cell will circulate and ultimately will come out as what we'll call a memory B cell. It'll learn how to fight certain infections in your body, or it can sometimes come out as a plasma cell. And what happens generally, and this is a big picture hand-waving cartoon, so to speak, is at some step of the way, it stops. When it should continue to mature and maturate, it stops and then starts to grow somewhat uncontrollably in that zone or in that area. So if it gets stuck in the marginal zone, as you can see in the upper left, or it gets stuck in the germinal center. Now there's other events and other things that have to happen, but this has been a big part of research. We've known this for 15, 20 years on literally dissecting these areas. Why does it get stuck there? What other events have to happen for this to grow out? So this is part of understanding, yes, it's all B cell lymphoma, but all the different subtypes within the B cell and the maturation, et cetera, of the cell that can happen. So really, you've probably heard the term precision medicine, and that can mean a few different things. And really, what I think precision medicine is becoming more individualized, becoming more targeted, whether it's looking at the DNA, literally. And that's a lot of what we do, and I know Dr. C does a lot of that, literally studies the DNA and RNA of lymphoma cells. It's very abnormal DNA, and there's billions of different things going on sometimes inside the cell, so it's almost looking for needles in haystacks sometimes to try to analyze this, and it can change over time. And how does that help us? Well, it helps us with diagnosis, helps us with prognosis, and it can also hopefully help us with treatment. Now, we've known for many decades we all have chromosomes in our body. We've known for many decades that the chromosomes can get altered. They literally can get flipped on top of one another abnormally. And when that happens, that can cause abnormal cell growth. So we've known that. We were able to take pictures many, many decades ago. We're able to study this with very sophisticated techniques now. And what this is, I'm showing you, this is again a very complex slide, but this is what's called a gene expression. And what you have here are in all the different columns, many, many different cases, and then you have different genes. And you're able to it's almost like studying patterns. And can we figure out within not just individual patients, but then grouping into certain groups based on the DNA, RNA of that lymphoma. And this can, again, lead to very exciting diagnostic and therapeutic discoveries that will help us. And this, what I can mention, this gene expression is not in the clinic yet. It's not ready for prime time. I'm hopeful in the next 5-10 years, it could be something we're at the bedside or within a day or two, send a tissue off, get a gene expression signature of that individual patient, and really tailor the treatment according to the individual lymphoma genes. So, and there'll be much more about this Dr. C will talk about in terms of diagnosis of lymphoma. What about the pre-treatment evaluation once it is diagnosed? Well, there are some similarities. Usually, as you know, there'll be blood tests. There's some similar ones. There will usually be some scanning, whether CAT scans or PET scans in certain types. Sometimes we'll do a bone marrow. I mentioned that lymphoma is in the blood. Well, where does all of our blood come from? Inside the bones. So sometimes we'll sample. It's still treatable if it's there, but we want to see, is there lymphoma in the bone marrow. So we don't always do that, but sometimes. And of course, our goal, if lymphoma is diagnosed, is we want to be in remission and cured, and we want to do no harm. So as part of that, because if we are using chemotherapy, sometimes the heart or the lungs can become irritated, so we'll check that ahead of time with an echocardiogram. And in some cases, it can spread to the spinal fluid, or even we think of the brain. So sometimes we'll not only test with spinal fluid and an MRI, sometimes even give what's called intrathecal chemotherapy in certain cases. And fertility, certainly for our younger patients, is a very, very important consideration to think about ahead of time as well. Okay, so a couple on non-Hodgkin's and then a couple on Hodgkin's. So this does not represent certainly all 80 types. What this pie chart shows is just some of the more common subtypes. So what is number one most common subtype of the 80 in the United States and frankly the world is called diffuse large B-cell lymphoma, represents about a third of all diagnoses. But as I'm going to show you in a minute, there's heterogeneity within that 30%. Second most common is follicular lymphoma, and you can see some of the other subtypes listed. So just as an example of, I think, the challenge, but more the excitement as we learn more about this, when we say diffuse large B-cell lymphoma. So it can mean there's different stages, early stage, advanced stage, all treatable and hopefully curable. You can see there, but then you get into some other subtypes that we think about. Something called T-cell histiocytic rich. Believe it or not, there's diffuse large B-cell that only occurs on the leg, called primary cutaneous type. There's lymphoma that only occurs in the brain sometimes, still treatable and curable, called primary CNS lymphoma. It can only be in fluid in the lungs. You can see it only in the chest. Believe it or not, it can only be in the blood cells. It's called intravascular diffuse large B-cell. I mentioned the post-transplant. That's a subtype. There's even a subtype in men. It can be only in the testes. You can see it only in the stomach. Sometimes there's HIV-related, there's an intermediate or double hit, and sometimes there's something called composite or transformed, where you do a biopsy and you see different subtypes of lymphoma. So this is the challenge when we're presented with a case where it's not often just one kind of subtype. We want to know all the details of the pathology, details of the location. So again, we can tailor that treatment exactly to the specific situation. And this is what we want to flesh out with every lymphoma subtype, to really expand it out and know exactly what's going on. Now, with that said, to think about it maybe in a little bit more 50,000 foot, all these different subtypes, another way to think about it is by clinical distinction. So I will often describe to patients kind of two categories, an indolent category and aggressive, very aggressive. And not one is good or bad, they're just different. And again, follicular, the most common indolent, diffuse large B-cell, the most common aggressive. All treatable, but of course a little different in terms of the natural history. Also, what can happen, even if someone's diagnosed with an indolent, in particular follicular lymphoma, sometimes when it comes back, it can come back as aggressive. That's what we will sometimes call a transformed lymphoma, when it goes from indolent over to the aggressive. Still treatable, but the treatment, as you can imagine, is a little bit different. What about what we use a word called prognostication? In other words, we make the diagnosis, we have the staging studies. Can we use factors to help guide potential outcome and even hopefully with potential treatment? So there's something called the International Prognostic Index, IPI. So those 5 factors I have listed there compose the IPI. And it kind of gives us different categories, and we've used this in some of our clinical trials. But really the future, as I alluded to before, is the molecular, the really deep sequencing. And we're starting to learn that. There's a lymphoma called, grouped by a name called a double hit. Double hit means 2, remember those chromosome changes I showed you? If you have 2 specific chromosome, or 3 sometimes changes, MYC and BCL2, we know that if you give typical chemotherapy like rituximab and CHOP, might not be good enough. You need to give something else. Well, we really didn't appreciate this 10 years ago, but a lot of great research has led to this to now say, okay, if this exists, we need to treat with something else. And now what do we have? A lot of clinical trials specifically for double-hit lymphoma, where before we really didn't appreciate it quite as much. So you'll learn a lot more about treatment in a few minutes by Dr. Sotomayor in terms of treatment and Dr. Kelly about clinical trials. Okay, last few slides on lymphoma. Believe it or not, that is Sir Thomas Hodgkin, a painting in England. And in 1832, a little while ago, 1832, he had several patients with lymph node enlargement that he wrote up in a paper. And it wasn't called Hodgkin lymphoma until 70 years later when a couple of pathologists, Dr. Reed and Dr. Sternberg, named the diagnosis Hodgkin lymphoma. And I don't like showing survival curves, but we do look at these a lot, and I wanted to show this for one purpose. These are survival curves for Hodgkin's lymphomas. And it highlights a couple things. So in the 1960s, how did we treat cancer in general? We really didn't, believe it or not. And we maybe used radiation a lot, certainly surgery. If we used chemotherapy, it was one drug at a time. And so Hodgkin's, if you use radiation and one drug at a time, you could have cured 30% of patients. But I don't know if anyone's read the book or seen the show, The Emperor of All Maladies. They talk a lot about in that acute lymphoblastic leukemia, ALL, as really the first breakthrough. Well, the second was Hodgkin lymphoma. And Vince DeVita and some other colleagues, based on science a little bit back then, cobbled together different drugs into a regimen called MOPP, M-O-P-P. And literally, not overnight, but over a few years, the cure rate doubled. In other words, we learned that one drug at a time, if you put 4 drugs together, because cancer cells can be smart and these drugs each work different ways, so this combination of chemotherapy literally doubled the cure rate. And as you can see now, the Hodgkin's lymphoma, generally speaking, we cure about 90% of patients with Hodgkin's lymphoma. And it's interesting, though, because the biology really came a little bit after understanding some of those clinical advances. Part of it is Hodgkin's a little different. When we do a biopsy of a Hodgkin's lymph node, 99% of the cells are not cancerous in that lymph node, only about 1% or less. So it can be a little tricky. It wasn't until they were able to literally micro-dissect out these Reed-Sternberg cells and start to do science that we were able to understand that. So just one, in terms of the incidence, a little different. Remember how you saw that steeping curve up? For non-Hodgkin's, you see this what's called bimodal curve in terms of incidence of Hodgkin's. In other words, we see it most commonly in patients in their 20s and 30s. Kind of goes down a little bit and then comes back again, 70s and 80s. And we think it's mostly similar, could be slightly different in terms of how we approach it. Clinical presentation, I would say, is similar to non-Hodgkin's, which is kind of non-specific, but in terms of lymph nodes enlargement, sometimes it be symptoms, a few unusual symptoms like itching, or we use the word pruritus, sometimes that we will see. What is the approach to Hodgkin's? Really, the goal, like the aggressive non-Hodgkin's, the goal is cure. In other words, go into remission, never come back, A, and B, do it with as little amount of therapy as possible, because we know, especially if they're younger, we don't want to cause side effects, not just acutely, but later in life. So we're very cognizant, and you'll see several talks and symposiums on survivorship. And it's not just for Hodgkin's, all lymphoma survivorship is critical. So thankfully, the LRF and others are really dedicating a lot of effort towards survivorship. And we have experts now leading those charges. So that long-term follow-up, just to continue that, I think is critical. Yes, we want to focus on the acute treatment, getting into remission and potentially cure, but we want to think about quality of life, and that's a lot of survivorship. But there's other parts to survivorship that are critical, and now we're starting to see experts and specialty clinics exactly in this be created, and research groups as well. So in summary, as I showed you in this short time, there's been a boom of knowledge over the last few decades and years about the causes and especially the biology of lymphoma. We know non-Hodgkin's is heterogeneous, different clinical pathologic subtypes with different natural history. Hodgkin's a little more homogeneous, goal of cure, and certainly really attentive to late effects. And really, it is an exciting time of not just the different treatments with all the new diagnostics, and how do we do it? Clinical trials. I mean, that's how we take it, the next step of learning about the new treatments and learning not only the safety and not only the efficacy, but who does it work in? Who is it best for? As we continue to fine-tune everything that we do. And with that, I'll say thank you.